Hello, sir. Good evening.
Hello.
So, computer
Good evening. How are you?
started with the laptop. Last moment पे it don't switch off. Now I'm trying कि वो तो नहीं हो रहा, but let's see इससे हो जाएगा नहीं. Tell me one thing, sir. Is my voice is clear?
Yeah, voice is clear.
Shall I show my screen also? Because
Yeah, let's just take a try.
yes. Screen.
ये किससे आप कर रहे हैं?
I'm doing from laptop, sir.
Okay, fair. वो जो बीच में एरो है उसको दबाइए. Present now your entire screen and then press on the center and share.
So present screen is visible, no, sir?
Not yet visible, no.
Not yet visible. Okay. Okay, now. So now is it visible, sir?
Yes, now it's visible. Okay. Make it full screen, yeah, please.
Yes.
Yeah, fine. Just press that hide thing so that
yes.
Yeah, perfect.
Oh, it has gone.
Just press the PowerPoint नीचे. ये PowerPoint आप अपने task bar में हाँ आ गया ठीक है हो गया.
Let me see एक बार. सर स्क्रीन पे विजिबल तो हो रहे होंगे, I hope, है ना?
हाँ एकदम सब कुछ सही चल रहा है, कोई टेंशन नहीं. वापस. You can stop sharing. We'll start.
Okay. Shall I start or?
No, you just stop sharing. I'll share my screen, introduce, and then start.
Okay, sir. Stop sharing. Yes.
Yeah, fine.
Somehow camera is not working, I think.
No, camera is also working. Everything is working.
It's working because I'm not able to see in this. So.
I can see you very clearly and everything is fine. So are we ready to start?
Yes, sir. Yes.
Good evening, everybody. Welcome to this evening episode of Pursue. This is Pursue 19L, which is Hematology, Hemostasis and Thrombosis. We are streaming live from PGIMER Chandigarh via Kolkata. A very interesting topic, hereditary thrombophilia. And to speak on that, we have somebody who's an expert in thrombosis and bleeding disorder. We have Dr. Narender Kumar. He's an MD from PGI Chandigarh. Presently, he's a professor in the Department of Hematology at PGI Chandigarh with field of interest in laboratory workup of thrombotic and bleeding disorders. So the right person to talk on the right topic. With more than 80 publications in national and international journals. He's also the principal investigator of a national task force and national registry on venous thromboembolism, an ICMR funded project. Before I ask Dr. Narendra to start, let me request all of you to keep your mic muted, your camera off, and please do not share your screen. With this, let me request Dr. Narendra sir, please share your screen. Let's start.
Hello, good evening, everyone. Thank you, sir, for giving me this opportunity. And so the topic that I will start is on hereditary thrombophilia. And in this, I would say thrombosis is one of the commonest complications with which the patient routinely present, and the main problem is they will present with the history of thrombosis, or you can say the venous thromboembolism. So if we talk about thrombosis or thromboembolism or thrombophilia, basically thrombophiliia is a state in which there is hypercoagulability, and or you can also say that there is a prothrombotic state. So any inherited or acquired abnormality that is happening in the hemostatic system. Our normal hemostatic system is maintained like this, that in the circulation the blood should be in a fluidic state, and whenever there is injury is happening at that place, that your prothrombotic factors they start acting and they will lead to development of thrombosis, while in the rest in the fluidic state that remains in the anticoagulant, or you can say that without any coagulation state. Any problem or any inherited or acquired abnormality that leads to intravascular changes that leads to thrombosis is known as hypercoagulability or thrombophilic state. And obviously the patient with the prothrombotic state or with risk of thrombophilia, they present with the manifestation of thromboembolism. So if we talk about the risk factor of venous thromboembolism or thromboembolic state, these are broadly divided into two categories. One is unprovoked or non-environmental, and second is provoked or environmental. So this provoke or environmental group, this is quite huge group, and this is subsequently divided into persistent and transient. Persistent means anything that is happening continuously and that is not changing, and transient that is happening for a few time period and subside after that. So if we talk about the persistent thing, these are the commonest one, any active malignancy that is going on, or patient is having antiphospholipid antibody syndrome, patient is of routine you can say the patient is having either CHF, obesity, kidney disease, or patient is of paralysis. These are the things that won't change frequently. So if the patient is having, that means it will persist for a longer time. So these are basically the risk factor that can lead to the development of thrombosis. While in the transient one, this can be divided into major or minor. And in the major, when it is surgery under GA more than 30 minutes, or patient who is confined to bed for at least 3 days, or if the patient underwent cesarean section. In the minor one, if the surgery is happening in less than 30 minutes, or the admission time period less than 30 minutes, or patient is on estrogen or therapy, or pregnancy, or postpartum period, or prolonged air travel. So basically these are the commonest factors. And then there is certain other group that is known as non-environmental or unprovoked. In that, male is one of the known risk factor, although it's we can say that common in female, but it can happen in males also. And one of the major thing that we will discuss today is about the hereditary thrombophilia risk factor. So this is the part of a known environmental thing. So the environmental things you can easily change, but the known environmental you cannot change. So patient need therapy for that. And if we talk about the risk of recurrence, that is basically this is the area where the clinician wants to tackle whether this patient is having risk, because usually the patient present with the history of thrombosis, that means the patient got that abnormality. But what is the future of that, whether the patient will get again that thrombosis or not? So this is the area where the clinician wants to know, and for that we have to perform the testing. So if we talk about the risk among the unprovoked risk factor, is a mediocre risk as compared to the transient or persistent provoked risk factor. So if we talk about the pathogenesis of development of thromboembolism, so it basically happening because of the defect in coagulation system. Either there is enhancement of procoagulant action or there is impairment of anticoagulant action. Any of the step arm which is defective, or is there a change that is happening, that leads to thrombophilia state. And this could be inherited one or this could be acquired. So whenever any hematopathologist who is discussing the coagulation related any disease or any abnormality, so they will discuss about the coagulation cascade. I won't go in detail of this. My whole purpose for showing this is that in the coagulation cascade there are two pathway, intrinsic and extrinsic, and that ultimately will leads to common pathway and then formation of clot, or you can say that fibrin mesh is formed, that is known as formation of clot. But now the thing is where this we know all that ultimately thrombosis is forming, but why this is not happening inside our body? And this is because of the natural anticoagulant. And these natural anticoagulant they will not allow the activity of these proteins or factors, and they will stop further action leading to the formation of fibrin meshwork. So they ultimately, in normal physiological condition, they won't allow formation of blood clot inside the vessels. So if we talk about the inherited or hereditary thrombophilia condition, anything that is happening in either protein C, antithrombin, protein S, if there is deficiency of these one, that will enhance these activation or these activated protein more, and that will leads to more production of the thrombi or more generation of blood clot. So there are enough literature on the development of thrombophilia or a thrombophilic risk factor, and through this publication there are review articles that says that there are some abnormality that have strong supportive data to say, okay, these are associated with the development of thrombosis, and these are antithrombin deficiency, protein C deficiency, protein S deficiency, factor V Leiden mutation, prothrombin gene mutation. Then there is another group in which there is supportive. Before that, I want to say that when we say that okay, there is strong supportive data regarding the development of thrombosis through these abnormality, so it is recommended that you should perform testing for these abnormality whenever the patient with thrombosis came. And then there is another group in this, there is supportive data to say, okay, this can lead to development of thrombosis, but actual prevalence or how much it is affecting or how much it is affecting to that leads to development of thrombosis, that is also not so strong. So, and in this there is increased level of fibrinogen, prothrombin, factor 8, factor 9, or hyperhomocystinemia, dysfibrinonemia, or you can say fibrinolytic disorder. If there is abnormality in the fibrinolytic disorder, so that means whatever the clot is formed, that will not get destroyed. In this, many people support, okay, we should do testing in these, but there is certainly other group there that will say that no, there is no need to do, because thrombosis is usually a multifactorial disease. It might be one of the reason, but it is certainly, it will not affect much. And then there are one more group of abnormality that is known as weakly sportive data. In this we have weak information. Okay, this can lead, but there is certainly after a few days some more publication will come, and that will say that okay, this is not affecting, or that is not having significant correlation with the development of thrombosis. And let me tell you, in this group, almost every 2 or 3 months one new factor will get added, and again after a few months one more come and other will go out. So people usually avoid testing in such cases, or in people usually avoid testing of these marker in the cases of thrombosis. So if we talk about the risk of development of thrombosis through these marker, among these, factor 5 laden, although the disease is multifactorial itself, the factor 5 laden is having the highest risk of development of thrombosis among the in general population, and also in the venous thromboembolism cohort. And this is followed by prothrombin gene mutation and protein C deficiency. The prothrombin gene mutation is quite peculiar. It is more common in the Western population, or you can say Caucasian countries, rather than all over the world. And so with this background, we'll start the individual through this thrombin thrombomodeling complex, and its basically function is to inactivate factor 5 and activated factor 5 and activated factor 8. So ultimately, inactivation of these will halt your coagulation cascade, and thrombosis won't happen. The half-life of activated protein C is 15 minutes, which is quite low, and its normal plasma level ranges between 70 to 140%. And if we talk about the deficiency of protein C, it's autosomal dominant but incomplete penetrance. Incomplete penetrance means although it is the disease is autosomal dominant, but it's meaning that if suppose if a patient is having any this abnormal gene, but it will not always that patient will have chances of, or every patient will develop thrombosis, and its prevalence in general population is 0.2 to 0.5%. And there are two types of protein C deficiency. One is known as quantitative deficiency in this, and other is qualitative deficiency. The quantitative deficiency is due to missense mutation, and it is much more common as compared to the qualitative deficiency, in which that is happening due to point mutations. The patients with the quantitative deficiency are mostly heterozygous, and how will differentiate between two? These quantitative one will have both the functional activity and immunological base antigen level, you can say. These are both will get reduced in this, while in the qualitative one the patient will have normal protein C antigen level but with decreased functional activity. If we talk about the symptoms, patient usually are asymptomatic until unless he developed multifactorial reason to develop thrombosis, and the heterozygous patient usually present in the adult age whenever they have other risk factor, and that also contribute to the development of thrombosis. And patient will have recurrent venous thromboembolism, or rarely they can have arterial thrombotic event also. But homozygous patient, they usually present in the early age, and one of the commonest diagnosis for that is neonatal purpura fulminans. In this, the patient present with extensive venous arterial thrombosis or skin infarction or skin necrosis, or you can say that the patient may have the with DI present with DIC, and in this we do factor. In this we do protein C level, they usually come very low, less than 5%. While in the heterozygous, they usually range between 20 to 40, even up to 50%. They are there. Another abnormality through which the patient come for the investigation is warfarin-induced skin necrosis, and this happen in the heterozygous cases. This is happening in the adult one. So, what is happening that suppose a patient require a large dose of warfarin, and the action of warfarin is that they will affect the vitamin K dependent factors. So what will happen if we give the dose of warfarin? It will stop the production of all vitamin K dependent proteins, and since this protein C is having very short half life, 15 minutes, so it is the first one that got affected, and its action or the activity of low protein C that will manifest earlier as compared to its anticoagulant protein that is the vitamin K dependent other proteins. So what will happen before the development of anticoagulant effect of warfarin, patient will present with thrombosis, and so to prevent this, the clinician usually give heparin as a coverage so that the patient won't develop this skin necrosis. So net effect of if suppose we won't give warfarin and we give this we won't give heparin and we give warfarin only, so the patient will develop microvascular thrombosis affecting the dermal vessel, and the patient present with the widespread skin infarction. There are certain acquired causes of protein C deficiency, also like vitamin K deficiency, which I told that warfarin, or patient is having liver disease or malnourished patient. In the DIC, also there is consumption of activated protein C, and that can lead to acquired deficiency of protein C, or in case patients with nephrotic syndrome, that can also patient can have acquired protein C deficiency. If we talk about how we diagnose in the laboratory, there are two types of assay. One is functional assay, and second is immunogenic assay. Functional assay are the either clot-based assay, and now most of the people have shifted to chromogenic assay, because the clot-based assay there is a lot of dependent on the another factors also, and especially these patients with thrombosis usually have one of the most common acquired condition, that is known as antiphospholipid anti-syndrome, and in that lupus anticoagulant will be there, and that will certainly affect its clot-based activity of protein C also. So most of the people with time are shifting to the chromogenic assay for protein C activity, and the other assay is for the quantitation of protein C, and that is known as immunological assay, and in this people need to perform ELISA. So first test, if have to be performed, then it should be the functional assay, and that should be the chromogenic activity. If any abnormality is found, then people if want to do, then they can do immunoassay, and usually the requirement of immunoassay is needed if the clinician wants to know whether this is type 1 disease or type 2 disease. Otherwise, in normal routine, chromogenic assay is sufficient to tell that okay, this is protein C deficiency. And if you want to go beyond further, then obviously you can do DNA testing to categorize, okay, this patient is having this molecular deficiency, or if you want to exclude that this patient might not have acquired cause of low protein C level, then you can go. Well, one of the basic technique that usually people in laboratory do, that if a patient is having low level, then they try to do repeat testing of that, and that may be after 4 weeks, 6 weeks, or more than that. The whole idea behind this, that if the patient is in acute stage, or if the patient is having any hepatic symptom, or those, if those get settled, and then do so that you get idea, okay, this patient is now free of acute stage, or the other function get normal. So you do repeat testing at that time. If still that is showing low, then your suspicion of inherited condition will get raised. So next we will move to the protein S deficiency. Like protein C, protein S is also vitamin K dependent protein, and this is also produced by the liver, but along with this, it is also produced by endothelial cells and the megakaryocytes, and its half-life is much higher than the protein C. Here, there we discussed about that was 15 minutes, here it is 42 hours. And in normal blood, it is circulating in two forms. One is free protein, and other is that is bind to C4b binding protein. And it is basically the free form that form complex with protein C, and that will destroy the factor 5 and factor 8. Along with this, protein S itself have interact with factor 10 and factor 5, and that also leads to inhibition of prothrombin activation. Its range, it ranges basically between 74 to 146 in male, and 54 to 123 in female. This is also an autosomal dominant condition. Its prevalence is lower as compared to protein C in general population. And this is of three types. One is quantitative deficiency. In quantitative deficiency, there is decrease in total protein S antigen, and along with the reduction in free protein S and antigen and protein S functional activity. And type 2 is divided into two parts. One is qualitative abnormality. In qualitative abnormality, there is normal total free and free protein S antigen, but there is diminished in the functional S, and that is approximately for 2A. And type 2B is that in type 2A, normal total protein and free protein S antigen, those are normal, but in type 2B, total protein S antigen is in the normal range, but the free protein S antigen is reduced along with the functional protein activity. So like protein C, this is usually the patients are asymptomatic, but they have, when they have multiple factor risk factor, then they develop thrombosis. And in this, the patient, the clinical history or the clinical presentation is almost similar to protein C deficiency. And the reason behind this is that because both work together, that leads to the development of thrombotic condition. So the patient might have neonatal purpura fulminans, especially in the homozygous case. The heterozygous case again present with warfarin-induced skin necrosis. And there are proof that the protein C and even protein S both can have a role in the pregnancy losses also. Similarly, the acquired deficiency, since it is a liver product mainly produced by the liver, so anything that is happening to the liver, or if this is also vitamin K dependent, so vitamin K deficiency, warfarin therapy, all these things leads to acquired deficiency of protein S. So to diagnose the deficiency in the laboratory, there is functional assay, that is clot based assay, and other is free protein S antigen. So this functional activity, it's quite sensitive for the patient with the lupus anticoagulant. I mean to say these assays are affected by the presence of lupus anticoagulant and by the APC resistance. So both these leads to the false detection of protein, decreased functional activity of protein C. So hence most of the people now shifted to the free protein S antigen. We all know that free protein S, that is the antigen. Free protein S is the that protein that have the activity. So for this free protein S antigen latex immunoturbidometric assay is commonly performed, and in this free protein S that is absorbed through the C4 binding protein latex particle, and this trigger an agglutination and reaction with the second latex antigen, which is sensitized to this antibody against human protein S, and this degree of agglutination is directly proportional to the free protein S concentration in the sample. And the important thing is that this is not affected by the activated protein C resistance or lupus anticoagulant. And if you want to do the molecular testing, then obviously you can see the mutational analysis of protein S antigen. So now we'll move on to the antithrombin deficiency. This is also known as antithrombin 3, and its action is on the active 2A or thrombin or active 10A. In addition to these, it will also affect factor 9, 11 and 12. And this is also synthesized by liver. Its half-life is much higher than those the earlier which we have discussed. It's approximately 3 days, and normal range is between 280 to 130. Its inheritance pattern is also autosomal dominant. And if we talk about the activity, how this is behaving, let's discuss first the types. It is also two types. One is quantitative deficiency and other is qualitative deficiency. In quantitative deficiency, there is reduced synthesis of normal protease, this antithrombin, and in this both antigen and functional activity of antithrombin in the blood is reduced. And the heterozygotes usually have approximately 50% of the level, while the type 2 is a qualitative deficiency, and in type 2 there is a molecular defect that is happening within the formation of protein, and in this the immunogenic activity or antigen level is normal, but the functional activity is markedly reduced, and this is of 3 type. And that also these 3 types are divided on the basis of how where this site or where this domain that is showing affected. So if we talk about antithrombin, it has 2 sites. One is for the heparin binding, and other is for the binding of the thrombin or active thrombin. So if there is type 2 HBS, that means there is deficiency, there is abnormality at the site of heparin binding domain or heparin binding site. And type 2 RS means if there is a abnormality at the site of binding of active thrombin. And third type is type 2 PL, that is pleiotropic site, in which both antithrombin and the reactive site of binding of thrombin and heparin binding domain, both these get affected. And all 3 you will say that there is decreased functional activity, but the antigen level will be normal. So whatever the protein that is produced or antithrombin that is produced, that have decreased activity, but its level will be, if you do antigen assay, then the level will be normal. If we talk about the clinical feature, this homozygous deficiency or of antithrombin is incompatible for life. The patient die in vitro, in utero, and due to development of fulminant thrombosis. Almost always the patient present with the heterozygosity, and the patient symptom will be recurrent venous thromboembolism. And along with this, the other symptom is the patient might have resistance to heparin, because there is a this antithrombin have a site for the binding of heparin, and heparin activity increases much more time if they bind with antithrombin. So these patients will have insensitivity to the heparin. So, and this is how we can detect this. The patient might have normal or minimally affected APT level after receiving a large dose of heparin. The acquired causes are usually the liver associated or the DIC. DIC is the commonest phenomena in this all the procoagulant or anticoagulant factor, all that consumed leads to the development of thrombotic like feature also, bleeding type feature also. And for the lab diagnosis, you need functional assay to detect the activity, and for this, the chromogenic assay is the best. And for the immunological assay, ELISA you can perform. And if we talk about the algorithm to how we can diagnose this type 2 disease, suppose if we do functional assay and if it is showing the reduced activity, and then it could be acquired also, or it could be inherited also. Always we have to exclude for all, regardless of any natural anticoagulant deficiency, we have to exclude first the acquired one, and for that always try to do repeat testing, never give report on a single test value. So first always think that this could be probably acquired and then do repeat testing. So if you find any reduced antithrombin activity, then see whether it could be acquired or not. If acquired, then repeat the assay after at least after 1 month. And if you think no, this is not acquired, then do antigenic assay also. If in the antigenic assay it is low, then if the antigenic assay is low, then that is looking like type 1 disease. And if antigenic assay is normal, then it is looking like type 2 qualitative disease. And for to categorize these three types of type 2 deficiency, you have to do sequential analysis. Since we are living in a developing country, I can tell you that hardly any center is doing molecular analysis for confirmation of the inherited condition until unless they have certain reason to do this. Usually the clinician are also not forcing for this, because once you have detected that okay, this one is having deficiency, the patient will need anticoagulant, and the patient there is no major change in therapy even after knowing that okay, this patient is having inherited changes. The only thing, be watchful or even after giving anticoagulant, whether this patient is not developing any recurrence of thrombosis in future. Then is the resistance to protein C activity. So we all know that activated protein C along with protein S that degrade factor 5 and factor 8. So this is the normal action of activated protein C. It will inactivate factor 5 and factor 8. And when we say there is resistance to activated protein C, it means that inability of protein C to cleave or to destroy the active factor 5 and factor 8. And what will the effect of that? If the activated factor 5 or factor 8 is there that cannot get destroyed, then there is that will leads to more generation of thrombin and more generation of fibrin, and ultimately leads to a hypercoagulable state. And if we talk about the various causes of activated protein C resistance, it is either hereditary or acquired, and the commonest or inherited condition that is known for activated protein C resistance is the factor 5 Leiden mutation. And the acquired causes, it could be pregnancy, it could be the presence of lupus anticoagulant, elevated factor 8 protein, reduced factor protein C or antiprotein C antibody. Even if we talk about the activated protein C resistance causes, this factor 5 Leiden is the most common one. Maybe more than 90% of the cases always have presence of factor 5 Leiden mutation. So instead of doing testing for doing workup for these or doing testing for activated protein C resistance, most of the people try to do factor 5 Leiden mutation. So let's discuss about factor 5 Leiden mutation. So this is the most common inherited thrombotic condition, and it's quite prevalent in Europe with a prevalence from 2.8 to 14%, and in India its prevalence in I would say India and in the Asia it's prevalence ranges from 1 to 5%. And in this, approximately 20 to 25% of the patient present with the episode of DVT. Excuse me. And 90 to 95% of the patient with factor V Leiden mutation are heterozygous, and their pattern of inheritance is autosomal dominant. The homozygous mutation is also there, and these patients present with early onset and also with a severe disease. So this factor 5 is this act as a cofactor for activated factor 10, and that leads to the generation of thrombin. And this protein C and protein S complex, this will cleave factor 5 to activated factor 5. And under normal circumstances, what will have this factor 5 gene have three areas where this arginine at the 506 position changes. The amino acid that is changed from arginine to glutamine in factor 5 Leiden. In under normal condition or normal factor 5 gene or normal factor 5 protein, it is the arginine, and that changes to glutamine. So, and this is happening in the factor 5 gene of the chromosome on the chromosome 1. And what will happen if it is changes to arginine to glutamine? This site will become inactive, and hence the impact of the protein that is factor 5 that is produced through the factor 5 Leiden, that will not be affected by the this protein C, activated protein C complex. So patients with factor 5 Leiden mutation, they become less susceptible of the inactivation by APC, and its inactivation is approximately 10 times lower than the normal factor 5, and ultimately leads to prothrombotic state. And this factor 5 Leiden contribute nearly 92% of the cases of APC resistance, and the rest of the 8% cases of APC resistance are, which I discussed earlier. These are antiphospholipid antibodies, pregnancy, other mutation. So, although factor 5 Leiden mutation is a part of autosomal this activated protein C resistance, but these should not be considered synonymous. These two are a separate condition, because there are 8% cases which are having other reason to develop the development of this resistance. And the heterozygous patient usually are asymptomatic, even the homozygous present in the later age of life. And the heterozygous cases usually have 2 to 10 time increased lifetime risk of development of thromboembolism, while homozygous have 80-fold increase in lifetime risk. And since this venous thromboembolism is a multifactorial disease, more you have risk factor, more will lead to development of thrombosis. So suppose a patient is having heterozygous mutation, and along with this he or she has the various other risk factor, then the chances of development of thrombosis is much higher as compared to the patient who is having only factor 5 Leiden mutation. For the lab diagnosis, there is one assay that is known as APC resistance assay. In that, this is a clot-based assay, and in this activated protein C leads to inhibition of factor 5A, and that will leads to prolongation of APT. But what will happen in factor 5 Leiden mutation? This is factor 5 is resistance to APC, and so that will cause the less prolongation of APT. And the ratio of patient APT plus APC divided by the patient APT is calculated, and if the ratio is more than 2, then you can say it is normal. If it is less than 2, then it is a suspected case of factor 5 Leiden mutation, or you can say it is acquired cause. It might have inherited or acquired cause of resistance. Whenever you get the value less than 2, you have to perform the factor 5 Leiden mutation. Factor 5 Leiden mutation is PCR based, and that is RFLP PCR, and in this the restriction enzyme is used, and it digests the 220 base pair of the amplified fragment. And the normal human being will have three different bands. One is 116 base pair, one is 37 base pair, and other is 67 base pair. If we start thinking that okay, these are the two chromosomes, so if we see there are, you will see total three band out of these 220 base pair. The homozygous will have two base pairs. So instead of these 116, 37 and 67, the patient will have 67 and 153 base pair, while the heterozygous will have four band. One is of 116, 137, 67 and plus 153, which is coming through here. So homozygous will have two band, heterozygous will have four band. If we see the gel of this, in this case, you can see this one is of 116 base pair, this one is of 67 base pair, and this one is of 37 base pair. And these are the two cases of heterozygous, and in this you can see 153 base pair band is also there. So in this, although there is no homozygous factor V mutation case, but if it is there, then that will have 153 and 67, not this one, this band. Next is prothrombin gene mutation. So prothrombin or factor 2 that is produced by the liver, and it is also vitamin K dependent protein, and it will convert it to the thrombin, and this will activate platelet factor 5, 8, 9, ultimately cleave the fibrinogen to fibrin. And if there is mutation that is happening, it is the autosomal condition, and it is the second most inherited condition that leads to development of thrombosis or hypercoagulability. But this is quite common in Caucasian population, but its prevalence is quite rare outside Europe. And in this, this is a single point mutation, and there is guanine is at the nuclear position of 20210 is replaced by adenine and the prothrombin gene, and that will leads to the gain in function of prothrombin. And what will happen, that it will leads to increased level of prothrombin, or hence enhanced prothrombin activity. The patient with heterozygosity have nearly 30% increase in prothrombin level, and homozygous patient have more than 70% of as compared to the normal human being. As compared to Europe, among India, its prevalence is not common. This is one of the landmark paper from our department, from Dr. Reena Das and Dr. Gurjeevan Grewal and Madam Dr. Jasmina Aluwalia. And in that, they have studied that factor V Leiden was approximately 3% in our population, but we haven't found a single case of prothrombin gene mutation. Although there are few cases reported from CMC Vellore, other than that, I don't think there are cases of prothrombin gene mutation. And for testing of this RFLP PCR is done, and in that 355 base pair of the PCR product is digested by HINT3 restriction enzyme, which will divide into two fragments. One is 322 and other is 23 base pair. And the heterozygous patient usually have three band. One is 345 base pair, one is 322 and 23, while homozygous will have 322 and 23 base pair. This one is the heterozygous case. In this, you can see one is band of 345, other is 322, and third one is 23 base pair. So with this, we have covered all those abnormality which have a strong supportive data, and for that you have to do testing. Now we'll move to the abnormality which have supportive data, but there is always debate whether you have to perform this testing or not. So in this, you will start with first with hyperhomocystinemia. So this homocysteine is formed during the conversion of methionine to cysteine, and this homocysteine is metabolized by through two pathways which I will discuss in the next slide. One is sulfuration pathway and other is remethylation pathway. In transsulfuration pathway, the enzyme involved is cystathionine beta synthetase, and in remethylation pathway this is methyl tetrahydrofolate reductase. So this is that pathway. In this, the folate 5-methyl tetrahydrofolate, that is converted to tetrahydrofolate, and through this is through happening through methionine synthase, and or you can say that in this the methionine is converted to cysteine, and through this this homocysteine is produced, and this homocysteine will get uh, uh, and this hemocysteine will further changes to cysteine. So in this, these two pathways, one is remethylation pathway. Through this is through the methyl tetrahydrofolate, methyl tetrahydrofolate reductase, and through this this 5-methyl tetrahydrofolate is produced, and homocysteine get consumed, leads to formation of methionine, and in the other pathway it will get changes to cysteine through transsulfuration pathway, and the enzyme involved is this cystathionine beta synthetase. So if there is deficiency of either methyl tetrahydrofolate reductase or cysteine beta thiosynthetase, that will lead to accumulation of homocysteine. So the condition that can lead to hyperhomocysteinemia is either there is severe hyperhomocysteinemia, and that is happening because of homozygous deficiency of either MTHFR or CBS, and there is mild to moderate hyperhomocysteinemia when there is heterozygous deficiency of these two. And one of the commonest, or I would say ki out of 100 patients, probably 99.9% cases will have acquired causes of hyperhomocysteinemia. These are exclusively rare thing to have CBS deficiency or methyl tetrahydrofolate deficiency. So almost always the patients have usually the acquired causes, and among these the commonest one is the vitamin deficiency, either it is folate, B12 or B6 deficiency, and this is the reason why people do not want to perform testing. Always people say that you give vitamin trial, if that level get normal then it's better. Okay, this is most likely the acquired deficiency. So this hyperhomocysteinemia is one of the commonest risk factor for the development of both arterial and venous thrombosis, and it is considered as a significant risk factor for the vascular disease. And if we talk about its laboratory diagnosis, you can do fasting total plasma homocysteine level, that is can be measured by the ELISA or HPLC or chemiluminescent assay also, and its normal range between 5 to 15 micromole per liter. And if homocysteine level is increased, it's always better to do exclude vitamin D deficiency or give folate therapy along with vitamin B12. Then is elevated factor 8 level. So factor 8 level, although there is no genetic changes that describe factor 8 level, but high factor 8 level also leads to the development of thrombosis, and there are multiple causes. One of the commonest causes that this factor 8 level is known as a acute phase reactant. So whenever there is acute illness is happening, that will leads to production of this. So whenever the patient present with thrombosis, that is under, especially under the acute stage, they usually have high factor 8 level, that itself predisposes. So the other causes, any chronic inflammation, malignancy, active disease that is happening, that will lead to the increase in level of factor 8. So the factor 8 level is affected by the numerous external factors, including the acute phase. So it's always possible that the false positive test result you can get. And the inclusion for factor 8 level measurement in hereditary thrombophilia panel is always a matter of debate. The next is disorder of fibrinolytic system. This area is, I would say, that is least explored, and the reason behind this is difficulty in doing testing. So when we talk about the fibrinolytic system, I would say that plasminogen, that is the inactive form, that will convert into the plasmin, and it's the plasmin that will clear the fibrin meshwork, or that will destroy the fibrin meshwork, hence that clear the clot. So what will happen? Suppose I would say that under normal circumstances, this is how it is happening. But if suppose I would say that plasmin is not formed, so that clot will get together, and hence it does not get destroyed. So that means there is increased chances of thrombosis, and this conversion of plasmin gen to plasmin, that is affected by, or that is enhanced by tissue plasminogen activator, and there are certain antagonist of this fibrinolytic thing, and these are plasminogen activator inhibitor and antiplasmin level. So most of the institutes, especially in India, I would say, are not doing these testing, because one of the reason is the disorder of fibrinolytic system itself are quite rare phenomena, and their influence, especially on the thrombosis, is also not strongly established. So any deficiency of plasminogen deficiency, or tissue plasminogen deficiency, or excess level of plasminogen activator inhibitor or antiplasmin level, this all can lead to the development of thrombosis, or that enhance the formation of thrombosis, I would say. So with this, we are coming to the end of our seminar, and in the end I will tell how we deal with the patient with thrombosis. In this, there are two areas. One is that highlighted in the bold color, and other is a light gray, I would say those ones. So factor V Leiden, we routinely do protein C activity through the chromogenic assay, free protein S antigen through the latest immunoassay, and antithrombin activity through the chromogenic assay. These are the assay we routinely perform. Prothrombin gene mutation we are not doing, and the reason I told earlier that it is exclusively rare, and especially in the Indian population. S activity, all over the world people have shifted from this protein S activity, that is clot based assay, to the free protein S antigen level. Along with this inherited group, antiphospholipid antibody, this is the commonest cause of the acquired laboratory group, that is we can find for the patient of thrombosis. This is the panel, the part of our panel. In this we are doing anticardiolipin antibody, anti-beta 2 GP1 antibody, and lupus anticoagulant. There are certain group in this in which we are doing PNH through flow cytometry, or JAK2 V617F mutation, and this is in cases of this PNH workup is in cases of unexplained splanchnic vein thrombosis, or you can say uncommon site of thrombosis, or cortical vein thrombosis, and same is happening to the JAK2 mutation also. Homocysteine, earlier we are doing, but with time we realized that it's better to exclude the secondary causes. Even after giving vitamin supplementation, its level comes normal, but if we need then we can do in certain circumstances. So the take home message from this seminar is there are two type of abnormality for which a laboratory hematologist or hematopathologist should pay attention. One is the deficiency of natural anticoagulant, and in this factor V Leiden mutation is exclusively common, and followed by protein C deficiency S and antithrombin. Prothrombin gene mutation is rare in India, and for these things we have to do testing. And then there is another group which is supportive, in which supportive data is available, but these are not mandatory. If the clinician are forcing you, or they have strong suspicion, then I think you should do these testing. Otherwise, on the routine basis, it is not mandatory. So with this, I finish my this seminar, and questions and comments are most welcome. Yes.
Thank you so much, Dr. Narender. A very lucid presentation, very clear and very detailed. Let me just see if there are any questions on the YouTube. No, I don't see that there are any comments or questions there. A very nice presentation, I would say. Excellent. Would request you to share the PDF of this presentation. We will upload it on the Google Drive.
Sure, sure. I will give that, and I would say those who are listening this seminar, and if even they are interested or they want to know anything, they can email me also if they are not available.
Okay, thank you so much. Then we will share your email ID because there are a lot of questions which come afterwards. Most
Yeah,
of these
sure, sure.
these presentations are recorded and they're uploaded on the YouTube, and the questions starts coming from next
So I
day
will share my
onwards.
email ID and
I have your
yes,
email
yes,
ID. I will share that on the Telegram group. So if anybody
yes,
wants to have any clarification, they can directly get in touch with you. That's so nice of
yes,
you.
yes.
Right, so Dr. Narendra, thank you. We would like to have you again back on this platform with something more. I know you are very busy. If you get time, please let us know. Then we will again arrange
Yes, sir.
something.
Yes, I will.
Right.
I will let you know, sir. Yeah.
Right. Thank you so
Thank
much.
you, sir, once
God bless
again.
you. Good night. Take care. Bye
Yeah.
bye.
Bye, sir.